So thanks, Bala sir, and with the due respect to R.K. Sharma sir and Umla ma'am and Balakrishnan sir, I start today's talk. So actually, this idea was mooted by Dr. Sambat Kumar sir when he was discussing about the handheld ultrasound. How because I've been using for quite some months, and the sir wanted to buy one. So he asked over phone what is the utility, and I made some comparison. Then he said, why not, this topic can be shared on the inform meeting so that if people are planning to buy this, can think, and because the investment is quite, it's not high cost, but it's about 2.5 lakhs. It's no money, it's a dead money. We won't get any kind of a return from it because over the next 30 minutes, you will understand how. So, sir, am I?
Yeah, you are audible and your slides
visible. This is the handheld probe. Can you see this probe, sir?
Yeah. So this will go into the coat pocket, right?
Yeah, it's a coat pocket. So this is one. It's about. So actually, sir, when the topic was read, it's a USG now in nephrologist's hand. I think the audience might have thought that the entire process of doing the ultrasound. I think it's a handheld ultrasound talk today. It's the whole spectrum of ultrasound cannot be taken in nephrologist's hand, but it is. If any nephrologist learns certain basic things, it will save our time enormously. So this is what the point all about today. Talk. So actually, from the institution to an individual, I work here as in my own center, and I go to other institutions. If I visit, and I do transfer in some other centers where if I make morning round, if I ask them to bring an ultrasound machine, it takes a minimum 20 to 30 minutes, but by the time I would have finished some other work. So to save my time, the handheld ultrasound came very handy to me. And moreover, it's comfortable to carry, convenient, and you can judge the things very quickly. Then and there you can order certain things to the patient. You can promptly attend on patients in emergency situations. So though it is not wired, still it is connected from the institution to the individual. Anyone can buy, but the issues are there, some legal issues I'm not going to discuss openly on this forum. And even I don't want to disclose the name of the machine which I have right now. Anything you can talk to me over phone, and I can give some address where you can procure it. See, the wireless probe ultrasound is the new generation instrument for the ultrasonography with outstanding features like a wireless one. Here, the main unit is the wireless app on Android or iPad. Just you carry a laptop or even iPad, Android phone, anything, you can connect wirelessly. The main unit is the small probe, which has got a power unit, a transducer, which receives the image, and it does the high definition image processing inside. Then it transmits a image to the application which is installed on your phone or any laptop. That is the main unit. In fact, actually, it's only application where you can make all kind of adjustments and depth, other kind of brightness, everything you can. I'm going to talk a little bit in the next few slides. So the people are claiming that the manufacturer across the globe, I think there are 4 or 5 major companies are making this probe. They're saying there's 3-in-1 wireless ultrasound probe. It is a linear and convex and phased array. There is some caveats there, and I'm going to disclose it later, but it is really convenient. Linear, it's okay. Convex is okay, but if you phased array mainly for the echo probe, it has got some limitations. Actually, the main icon of the probe has got it is mainly it's in the application. Actually, you can have a gain, image gain, or reduce the image gain. Depth you can choose the smaller to the bigger one. You can adjust the focus. Dynamic range, it's a more granules to the more smoother one. Harmonic usually applied in echocardiogram. Here they're saying the image will the reflected image frequencies are captured, which produces more of a defined image. That's what the mechanism in standard machine. But how here the harmonics works, we don't know. But there is one application icon is there, and it makes some difference in the clarity of the image. And the denoise is a speckle reduction. It's otherwise known as despeckling. If you have a minor granules, if you just keep pressing the button, you will get a smoother picture. You have a B mode, bright mode, a B even mobile, motion mode, color Doppler, energy Doppler mode, and pulse Doppler. And you can put a patient information on that, age, and you can feed the date of year of birth, and it will calculate the age. And you can freeze, and you can play on the playback, and then you can have measurement. You can even measure the volume also. Biopsy, there is one application is called biopsy. In you can clear the data quickly, and you can save the image, and you can even save the video image, which I have showed on for 10 up to 10 to 15 seconds. You can store the video image. You can send across. You can store it in your computer for study purpose. So these are the things about this machine, and straight away go into the clinical point. And one moment you buy the machine, there are 3 QR code will be there. You can just scan the code. You will get application downloaded in your system. So first, as a nephrologist, we deal with a lot of critical care issues, and every day when you make rounds in a dialysis unit, some patients come with breathlessness. The battery of causes may be there, like starting from the inadequate dialysis to the uncontrolled hypertension to pleural effusion. And moment you sit with the patient, you just put a probe, you understand what is what, right? Most of our patients comes on irregular dialysis. You find, moment you put on chest this probe, you can find the pleural effusion. This is the one image which the first one is the one. It was attempted earlier, a pleural effusion. Later, patient developed some kind of fall in blood, hemoglobin, a huge clot inside. That's what you can see. That the another one is the fibrin strand. This is a large amount. Actually, they cannot measure the volume here. Even standard machine, you cannot measure the volume. By eyeball assessment, you can over the time you can realize. The moment you see that it all depends on the depth of the ultrasound, how much depth you are keeping on the your screen. Moment you do 10-15 times, and depending on the depth, you can assume this amount of fluid can be there. And approximately, if you make 800 ml assessment, that will come around 850 to give or take 50 or 100 ml more or less. So you can easily measure it. So this is the another one, clear right side. You see the effusion. This all images taken from this handheld probe. You can see the clear images. As far as this application is concerned, pleural effusion can be detected very accurately on this probe, and very convenient. You can take only a few seconds to make a diagnosis. And another here, this is the patient actually instantly just lying just prior to transplant. And this another center, I was called in for help. Just moment I do a handheld ultrasound on the abdomen, we can see the large calculus, the GB calculus. And this is the patient's before putting line. In my unit, I generally most of the time technicians inserting lines, temporal lines. So even I taught to them how to do a basic ultrasound on the echo, because even simple eyeball assessment will be enough. Sometimes patients may not be able to lie down, and the attending staff might force the patient to lie down, and he may get kind of compromised. So it's better to assess the cardiac system by just looking at the eyeball assessment of the left ventricle and dilatation of the left ventricle, left atrium, right atrium, all chambers, which will give a fairly good idea. And the reflection of the mitral valve give how much relaxation of the left ventricle is happening, and so many things you can just looking at the ultrasound, heart. Keep doing more and more, you tend to correlate very clearly according to the clinical status. This is another one. This patient is normal. Most of our patients have LVH, and these patients are good. And in this patient, you see, this is a poor LV. So before putting the line, and we will be a little cautious about all these patients, we can even inform the attendants that some catastrophe might happen during the procedure. So it's all we can decide within few minutes. So there's another patient. This is the previous one is the done. The echo was done at this probe. The second one is a standard machine. This is a standard machine ultrasound. You see the huge dilatation of the LV and left ventricle with the normal left atrial. And there's another mode, four chamber long axis, and you can see there's a normal one. This is a standard machine, but you make a comparison. There is no much difference you had, but you cannot make measurements accurately. But what we require from this probe is some kind of eyeball assessment. So it will make you even pericardial effusion can be detected quickly. So this is a probe, handheld probe image, and this is a standard image, standard machine image. So this is what this is the comparison I have made on this. Okay. Now this is another a patient who presented with creatinine 24 anuria. This patient a few days before. So this patient is a bilateral calculus causing bilateral ureteric obstruction. Been neglected for a few days, so that's why we don't give much dilatation for this patient. And we went for a bilateral acute and DJ stenting patient without dialysis patient recovered. See this is the kind of image. Both are same images. There is some adjustment in the dynamic range. The dynamic range changes the frequency of the probe. So, but you can see the multiple calculus inside. Even you can accurately measure it. But my experience says that even small calculus can be detected on this probe. This is another patient. So the routine just came for a checkup for 1.4 creatinine with mild albuminuria, proteinuria in the urine, but this is here small calculus detected on the left kidney. So kidney size is normal, images are good. So what you can see is the shape, the normal CM corticomedullary differentiation. Even you can see small masses in the inside the kidney. You can also detect, hydronephrosis. All these things you can detect. So now hydronephrosis. This is the case. This patient, single kidney, left kidney was removed for some earlier for a stagnant calculus, zenith of glomerular pyelonephritis. The other kidney was showing hydronephrosis. So this is all done with the handheld coupler. Line for line, this for IJV. You can see these images are so clear. I don't have an image of putting real time and a needle insertion, but this is what image you can get it. It's very easy to carry, and even the small cover you can put it, because even the sterile cover inserting into the standard machines for long wired one, you cannot insert the sterile cover so easily. When here you can use it, the small covers are available. You can just put on or you can just wipe the both ends with the antiseptic solution. Even you can as well use it without any but I don't think that's a recommendation is there or not. But you better to use the covered sterile cover sheet. But this is what the image, both longitudinal and shortcut image, and so some post-transplant patients. This is where I use this machine often. The moment I come out of the theater, and even inside the theater, I use it. But there is some compromise in the quality. This is what you can see. I'll compare the standard ultrasound machines. How they see the Doppler. What you see on this probe is a small area. But you can swipe it across. But you cannot with this cursor. You cannot cover the entire graft. So that one pole of the graft will be having, you can just, but once sweep, you can see the entire graft. But if you use the Doppler, color Doppler to power down in a spectral pattern, if you go, the cursor, you have to remember where the Doppler pattern was there, the color flow was there, in that location, you have to put the cursor. In standard machine, you can see the arterial flow. Over that point, you can put the cursor, but here that point is lacking. It's a great deficiency in this probe. So you have to remember where the interlobular flow, that or arcuate artery flow, and just remember that point. Even a small tilt in the probe might change your cursor directions, and you will not get any kind of spectral pattern. This is one big caveat in this machine, and this is what you see. So you have, if in a patient, even with a small, suppose you suspect renal artery stenosis, immediate thrombosis in the graft artery, even if you put a power Doppler, power is down you have written, PDS uses special processing to display the amplitude and strength of the Doppler signal rather than the velocity. So even however the small signal is there, the power will catch it. This probe is adequate enough to catch all the even small amount of the flow is there, because it takes the amplitude rather than the velocity as the picking point. So you can easily use this probe. You can find out the even if immediate renal artery thrombosis in the graft soon after transplant, you can find out whether there is flow or there's no flow. So in that way, it is useful. But putting a cursor across the graft on a special point, it needs a lot of experience. So this is what our patient. This is the Rajeshwari, when patient is ATN. That patients, every morning rounds I used to compare it. that pattern changed from, from diastolic cutoff pattern to the Nandi pattern, what I used to call that, both diastolic and systolic pattern with a very smooth. This is what the probe comes in handy even very quickly. You can make rounds. You just will not waste any time on particular patients. Moment you come out of that patient's room, that you are confident that you are not missing anything. This is another pattern, normal pattern in a patient. So post-transplant, every day you can make a round, and we can document. Even you can put a picture on the case file for documentation purpose. This comes very useful. So the another patient here. So patient we transplanted. Soon after 6 hours, patient did not produce urine. There's so many speculation about the graft viability. First, bladder was empty. The attending staff removed the Foley, they inserted again. This kind of manipulation can be avoided if you have a hand probe inside. Just put the graft over suprapubic area. If the bladder is empty, then you think about other causes. So moment I reached there, ultrasound machine was made in different centers, so it was taking time to reach. So I did a handheld probe, and this is what the flow is. But I'm happy that there is a flow, there is a pattern. The little this pattern, I'm very happy about this, but it's not totally annoying pattern. But some kind of acute tubular injury is happening, and the next day there is diastolic cutoff. Then after 10 days, patient started recovering. So I used to tell that by ultrasound probe, if you keep doing a color flow and a spectral pattern, it's a biomarker. So this is a normal standard machine. This is what I made a comparison. I'm not happy with this probe for entire evaluation of graft, but it helps me ruling out certain things. But I'm very happy with, I'm so comfortable with the standard ultrasound machines. This is what you see here. The graft look like, the color pattern of color flow, the entire graft, blinking very nicely from end to end. The power Doppler. Then this is what I mentioned about this. So the previous one is this one thing. If you in the color flow, you can put the cursor over exactly which area of the artery you want to see the flow. But that kind of work you cannot do in a handheld probe. This you have to remember where the flow is there. Then you have to go and place the probe and cursor. And sometimes it takes long time to catch that particular wave. That's one big caveat in this probe. But over the time you can learn, but it's not so for that purpose only you cannot discard using this probe. And this is what generally we in ICU patients, we can see the IVC clearly. You can make a measurement. It comes again in 30 to 40 seconds. You can do it. And you can see the hepatomegaly, the portal vein system, and gallbladder. Even in acute hemorrhage, if you're like a dengue, you can give a peri-gallbladder halo, and pleural effusion, right side pleural effusion. So many things you can derive from this from single area. You can find so many things. And this is a bladder. Many times anuric patients are in catheter inserted wrong. Without any necessity, just put the probe. There is your bladder, because many obese patients, you cannot palpate the bladder. So rather in a peripheral center, people used to catheter. They insert the catheter, then they find out patient is in anuric state. So those things can be avoided by using this probe. And you can see the bladder contour and serration inside the mucosal thickening, and all this thing you can find out from this probe. So this what the very clear images are there. Even children is very handy, because children, most of the time, many outside reports are saying every children I see in my OP, they are cystitis. But certain what you see over the time, even generally children will have a small thickening, visible mucosa. People are reporting as cystitis, because there is no other attributable cause. They tend to write like that, but many times culture negative, and which may take us in a wrong direction. So if you keep doing things more and more, you will understand how the bladder looks like in children. So renal biopsy, this is a greatest advantage to in our setup with people. They don't have any even an institution from one area to another area, moving from one department another department takes time, and you are dependent on somebody. And this is what this is a blown up image, and you may not get very clarity. This is what you have to adjust some kind of icon on your app, and you can find out. So this image is a blown up image. This is not quite clear. I'll go next image. So you can see this needle is visible, but most of us, we have a lot of experience doing renal biopsy, so we know where we are going. Our eye will point only to the tip of the needle, but the novice people, the initial people are getting trained in renal biopsy. I think this blown up picture may not give idea, but next I'll show you the things. Okay, This is our next one. This is very clearly. This is done on handheld probe. This is done today. We have done, see, this is, I see, from, I'm making impression over the just skin. That impression gives me idea where I'm going. So this is what I'm just putting the needle inside. It goes, it pierces the face here. It goes to pre-renal fat. And another image I'll show you here. So I'm going down. So I'm touching the capsule. So needle tip is so visible here. So what else you require? So this is another patient. So I'm making impression over the skin and see clearly. So here I'm just going down, penetrating the fascia and touching the renal capsule. Okay, now I'm the third image. I'm touching the renal capsule, needle is going in, I'm just removing it. So here, so another thing. So you can see clearly this needle. So what we should know is the trajectory of the needle and where we are going, and whether we are really going inside the kidney or not. That's the thing we want, and that information can be clearly gleaned from this probe. This is a standard machine. The same technique, but standard machine I'm doing, but there is no much difference. So CNC's needle is coming out. So the standard machine, and previous one is the this handheld ultrasound machine. I mean the probe. So this is one. Okay, I'll go further. And this is the routine clinical rounds in the dialysis unit. Patient had you switched over to CAPD. He came for AV fistula closure because he's having incessant cough, high flow phenomenon. So I closed the AV functioning AV fistula. Then for 10 days later, he developed kind of a painful nodule just proximal to the closure area. Just if you have a handheld machine, just what you see here. So inside is down is a radial artery. Upper, this above one is there is the thrombus inside a small segment of the area which is inflamed, and I'll check. So immediately you make a conclusion what we are doing, whether it is even pus pockets are there subcutaneously, where it is even below the vein there is any collection. All these things you can, but it is only confined to in the vein. It's inside the vein alone. And this is I trace the vein. It just there is some kind of segment which is not inflamed. We do not do anything. Just we apply some bandage and apply. I mean, if infection is there, we treat with some kind of antibiotics covering staphylococcus. That's all. So some AKI, any patient comes inside. This patient was anuric patients who were created on 8. The clinical diagnosis of rapidly progressive glomerular nephritis. So you can have a prominent pyramid, clear delineation of both right and left kidney. But still, I've been using that standard machine for a long time. I find a little different, but still I can correlate. But for the new people which is taking up this job, I think this even diabetic kidney disease also look like this. So they should have a comparison. Once they do use this probe, and they tend to compare, they must compare with other images done by standard machines, so that they can learn the comparison between this probe. Once you learn this probe, and this is like driving your own vehicle, and how some techniques you have to apply for your vehicle. If you drive somebody's vehicle, some difference you have to find. That's kind of thing. You have to make a lot of comparison and find out how this probe will have an image in AK and other situations, and so on. So it all comes by experience. So this is the same patient. A patient requiring dialysis. So I did just screening of the chest, a heart. So you have to know just what is the status of the heart. Many times, sometimes patient may be having underlying cardiomyopathy, dilated one. Patient may not exhibit symptoms. So while putting line, they may throw some kind of complications. So all this better to, before inserting a line, it's better to do some kind of echocardiogram, just eyeball assessment. If something strikes your mind that is wrong, I mean, is something serious going on, you can get an opinion from somebody, or you can make some kind of precaution measures while inserting the line. So this is the probe left side, and this is what I just made up my own stand for that. It's an iPad, just dialysis room, just any patient complains, just put a probe and see. So even a technician can do. If you start, then the technician ruling, they can rule out pleural effusion, some kind of even some cardiac incessant cough. They can see the left atrial dilatation. If even any experienced staff nurse can pick up all those things. So this is what the machines, the harmonics, focus, the dynamic ranges, depth, gain, plus minus, denoise, the despeckling. You have a B mode, patient data, freeze, measurement, and annotation is there. You can make right and left, all kind of annotation is there. And you can save cine mode about 15 to 20 seconds and save the image also. So this is for the B mode and the BM, that's a bright and mobile motion mode, and color PDI, power image Doppler, and power Doppler. So some caveats I found is echo. Echo, you cannot have a complete information on this machine, but definitely you can rule out certain things, especially poor cardiac function and pericardial effusion. Some if you've been using echo machine for a long time, even with this B mode, you can find out the valvular motion, how indirectly it can reflect the chamber's function also. Bile duct, you cannot, even common hepatic duct, common bile duct, you cannot define by this machine. Very pancreas, it's really difficult. And lungs, I've been using for a standard machine, but this have a real pitfalls in that. It is a long story to tell, but it's not, it cannot, subjective variation might be there to conclude any definite diagnosis on this probe. Hepatic venous flow, it's very difficult to assess, because as I said, moment you put the cursor, this cursor changes the location, then we may lose the tracing of the hepatic venous flow. Lower rim Doppler may be like simple vein thrombus, and the extension of the vein thrombus is very difficult to judge, and perforators and superficial system you can deep and superficial, but perforators you cannot identify with this this Doppler. Transplant kidneys, there are some limitations, but still you can rule out certain very acute situation. I mean emergencies like, but in a standard machine we can, for renal vein thrombosis, like you immediately you can put a graft and negative reflection on the below the baseline. Those kind of things you cannot define on this machine. You have a peak, systolic peak, and diastolic cutoff, and those things you can clearly flow. You can easily perigraft collection, ureteric dilatation, all these things you can define by this. There is more than enough. There is more than enough on this probe. So just conclude with this short video.
It's not easy, but through practice and practice and practice, practice makes what? Absolutely not. Dismantle that belief system. Practice makes improvement. You can always better your best. You can always go beyond anything that you have ever done. You'll never hit a state of perfection. You're always bigger than what you do. And so all you're looking for are new breakthroughs through practice and practice and practice. You'll get better and better and better.
Thanks, Bala sir and other panelists. And I hope I have done a little justification in my talk.
Thank you. Thank you.